you guys admit a lot. We are seeing a ton of ARDS now, and then how to manage the vent is very challenging in some cases, and part of that challenge is how to titrate PEEP. And hopefully today I will teach you a little bit of tools and review the data behind these tools as to how to use PEEP or how to titrate PEEP. Okay. So the objectives of this talk is, first we're going to talk about positive end expiratory pressure, PEEP, what and why. And we are going to review some ways we can titrate PEEP. We'll go over each way, goods and bads about it, and how to implement it in clinical practice. And then I'm going to share my personal approach. The case discussion, we're going to start with and end with, okay? So I'm going to start, who do we have first year fellows?
All of them, right?
All of them?
Yeah.
Okay, Dr. Haddadin. So you're in the ICU. You have a 53-year-old female patient, has ARDS, bad pneumonia, and she's African American, and she got intubated. They called you. This is the X-ray post-intubation, and the RT looks at you and said, "Dr. Haddadin, what vent settings do you want?"
Okay, so I mean the main things is like the pulse oximetry, how much he's hypoxic, the patient, so we can consider.
Patient is desetting in the 60s because you just intubated the patient and the X-ray looks bad. So they just want when the RT looks at you, the RT does not want to hear depending on hypoxia, right? Just give me what you're gonna answer the respiratory therapist. You're going to say some things. Say them now.
Okay, we start like 100% FiO2. We can put like 10 PEEP.
Okay.
What
mode of ventilation do you want to choose?
So we can start with assistant control, volume control mode.
Okay, so you want a volume controlled mechanical ventilation. Okay, and then you said the FiO2 is 100, right? Appropriately, you just intubated a very sick patient. The PEEP, you said what?
We can start with 10.
Okay.
And tidal volume, I mean, it depends on the body of the patients. We can start with the 450.
Okay.
And we can respiratory rate start with the 20.
Okay.
And see the response and measure the plateau and the peak pressure. We can go higher with a PEEP.
Okay, good. So you wanted to start volume control CMV, so VCCMV. You wanted to have a tidal volume of 450 based on the patient's body, you said, right? So usually we go by patient's height, not patient body habitus. I don't know if that's what you meant or not. And 450 is too much for anyone who has that bad X-ray. Okay, unless of course they're 180 centimeters or higher, then 6 milliliters per kilogram of their ideal body weight can actually be 420, 430. Okay,
yeah.
So I wouldn't, if I'm shooting in the dark, I would do 350 for a female, 400 for a male, and go from there. Okay, before we get a height and actually do the measurements. You chose a PEEP of 10, a respiratory rate of 20, and FiO2 of 100%. Why did you choose a PEEP of 10? We're not going to talk about tidal volume. We're going to talk about PEEP today, so or mechanical ventilation modes. So, but I want to understand, why did you choose a PEEP of 10?
So usually there is a relation between the FiO2 and PEEP. Like if you're going high with FiO2, we have to go with high PEEP according to the plateau, and it can help with the hypoxemia.
Okay, so I think you're referring to the PEEP table. So there are tables out there that are published that correlate FiO2 to PEEP. There is a high PEEP table and a low PEEP table, and a PEEP of 10 is not high. Actually, it is on the lower side, right? If you look at the PEEP table for FiO2 of 100%, the PEEP is in the 20 range.
Right,
okay,
right.
But that's fine. This is what you chose to start. This is your first gas: pH of 738, a PCO2 of 50, a PO2 of 76. The ventilation settings that you used were a tidal volume of 350, a PEEP of 18, right? Respiratory rate of 25, FiO2 of 100%. Would you do anything different, or would you continue the same strategy? And both answers, I think, can be valid.
Well, with ARDS, I mean PO the PO on the ABG is acceptable between 55 to 90, so 76 is okay, right?
Okay. Would you want to know anything more about the patient? Looking at the X-ray, is there something that strikes you that you may say, okay, maybe I need to do more?
I mean, I believe
Look at the X-ray
there's some
overall.
atelectasis on the left side of the lung.
You can, yes. So you're talking about asymmetric ARDS. So if it's not diffuse and symmetrical, yes, you may need to, and I don't know the answer to that, you may need to change your strategy. But if you look at the patient is morbidly obese. The X-ray cannot even show the sides, the armpits of the patient, right?
Mm-hmm.
You can tell or you can't tell from the X-ray.
Yes, I can.
There are two of you around her chest. So would that change the way you titrate PEEP? And the answer is yes or no.
Well, I think it's need like higher PEEP, but also, I mean, before that, I mean, I have to get the plateau pressure, peak pressures, making sure I'm not.
So that's true. Okay, good. So I just wanted to share this case with you guys. So you're right. For obese patients, we may need higher PEEP, but why is that?
It's need more pressures to open the alveoli because there's like extra pressures, compression on the chest, so you need higher pressure from the inside.
Okay, so that's why when I said a PEEP of 10 might not be appropriate. It may not be, but in this case, the patient is morbidly obese. I would go higher, right? But we're going to talk now about how you can actually titrate these numbers.
Is it better like to start like with a small, then you titrate it up?
Depending, no, not necessarily, because after you intubate, you sometimes de-recruit. And when you de-recruit, it will take a lot to recruit, okay? So sometimes people do, there are some vents that have we bought these, but we haven't started using them. They have a built-in recruitment maneuver, okay? So after you intubate, you do a recruitment maneuver, and the vent will actually show you how much volume you recruited, right? So it depends. Again, we're going to talk. This is the aim of this lecture. So I'm glad you have a question because hopefully this lecture will answer. Okay. So let's talk about what is positive end expiratory pressure. So this is the pressure that will remain in the airways at the end of the respiratory cycle after exhalation. Okay. So after you exhale the tidal volume, the pressure at the end is called PEEP, or positive end expiratory pressure. Extrinsic PEEP is set by the machine. The PEEP we do is extrinsic. We force it on the patient through the ventilator, okay? And PEEP is a therapeutic measure. Extrinsic PEEP is a therapeutic measure. You use it for a purpose, to recruit lung, improve oxygenation, okay? Now, auto PEEP is an intrinsic PEEP, and it's secondary to air trapping and dynamic hyperinflation. If the patient, for example, has severe COPD and requires a very long time to expire air, and you increase the rate to the point that you're not allowing the patient to expire, you will cause dynamic hyperinflation, meaning the patient will take in 300, breathe out 150, then you give another 300, 150. There will be a cumulative accumulation of air that results in intrinsic or auto PEEP, and that can be harmful, okay? But today we're talking about extrinsic PEEP, which is the PEEP that you're titrating on the machine as a therapeutic measure on the patient. So PEEP increases transpulmonary pressure or the distancing pressure of the lung. The transpulmonary pressure is alveolar pressure minus atmospheric pressure, and if the atmospheric pressure is 0, then the transpulmonary pressure equals the alveolar pressure, okay? For a given compliance, let's assume the lung is a balloon, like in these pictures. So at a PEEP of 5, you will have certain distension in the lung. And as you add more PEEP, you will cause more distension in that respiratory system that is made of a ton of balloons, small air units, okay? So if the compliance is the same and you increase in the alveolar system and the respiratory system volume. So you add PEEP. If you add PEEP, you will distend the airway units within the lung, the alveoli, and you will increase the pressure within these units. Every time at exhalation, the respiratory system will go back to functional residual capacity. Okay, this is a volume versus transmural pressure curve. The dotted line here is the normal lung, which is a compliant lung. A compliant lung is a lung that expands a lot with a little bit of pressure and recoils fast when the pressure is removed. It's a compliant lung, okay? So as lung gets diseased in ARDS, it becomes more stiff. You need more pressure to open up the lung, okay? Remember, we said at exhalation, the respiratory system goes back to FRC, okay? So that means the lung opens up and the lung closes down, okay? When you give PEEP, you prevent that complete closure, okay? So when you give PEEP, the lung is not gonna go back to FRC. As you see in this graph here, on exhalation, the lung is gonna go back to a certain amount of pressure that you set. Extrinsic PEEP, I dial it in using the machine. So I chose a PEEP of 10. The lung is gonna go back, but it's gonna stop at a PEEP of 10. That PEEP, that positive endoscopy pressure, is gonna prevent atelectasis, is gonna prevent the collapse of the airway units, the alveoli, and will keep them open. And that prevents atelectotrauma. So there is trauma every time the lung closes and opens up, and closes and opens up. That causes trauma to the lung. So if you use PEEP, you prevent atelectotrauma. If you also use PEEP, another benefit of PEEP is the amount of energy needed to inflate the lung is less, because you are starting from a point that is partially open already. You're not going back to FRC. You're not collapsing all the units and needing to put a lot of energy to reopen these units, right? So you use PEEP to reduce work of breathing, to prevent atelectotrauma, to increase the recruitable part, a part of the lung, and to improve gas exchange in the products, okay? So again, why do we use PEEP? Recruit alveoli, prevent atelectasis and electrotrauma, improve alveolar ventilation and decrease VTU mismatch. It is also thought that higher pressure will increase the solubility of oxygen across the alveolar capillary membrane, and it reduces the work of breathing. So there's a lot of benefit in putting a mechanically ventilated patient on PEEP. This is a study that showed different CAT scans in a patient with varying levels of PEEP. You can see in A on the left upper corner, they use 0 PEEP. And you can see that one lung is partly open, the other is almost completely atelectatic. They increased the PEEP to 11. They did not achieve much recruitment in the almost fully atelectatic lung. They might have inflated more the partially atelectatic lung, and that may be harmful in certain situations because it may have caused hyperinflation of that part of the functional part of the respiratory system. Then what they did is they applied the recruitment maneuver. They went to a PEEP of 40 for 40 seconds, and you can see when they maintained positive pressure at 40 for 40 seconds, they completely opened up both lungs. And then they slowly went back to a PEEP of 11 after 10 minutes from the recruitment maneuver, and this patient's this patient maintained both lungs open and his PF ratio improved. So the initial PF ratio at a PEEP of 11 was in the 170s. At the end of the recruitment maneuver, the PF ratios was in the 300s. And then at the end, after they went back to a PEEP of 11, the PF ratio was maintained at 300. So using zero PEEP did not help this patient because we could not recruit parts of the lung that are important and for lung exchange. At a PEEP of 11, you could not recruit the de-recruited lung. You needed to go much higher PEEPs, that's called the recruitment maneuver, but a PEEP of 11 would keep that part of lung that was open. So probably a PEEP of 11 is above the lower inflection point, and we'll talk about that. So that's why sometimes higher PEEPs are necessary. And this study clearly shows you using imaging and PF ratios how appropriate use of PEEP can help the lung. So I'm going to ask Saddam again. Saddam, what do you expect if I'm giving this patient 400 tidal volume? What do you expect the airway pressures to be in picture B versus picture D? They're both at the same PEEP, PEEP of 11. Do you expect the plateau pressure to be higher in B or in D?
B.
And why is that?
Because there is no much space for this tidal volume.
Exactly. So that's the idea also with PEEP and recruitment. You have sometimes to use higher PEEP because when you end up recruiting lung, the same amount of gas will redistribute in a larger space, and that will cause lower distension on the lung. I don't know if it's visible to you, but if you look and compare picture B to picture D, and both are at the same level of PEEP, you can tell that the inflated part of the lung in picture B is more distended than in picture D. So for the same amount of PEEP and tidal volume, you may have been causing damage to the only functioning part of the lung in picture B as opposed to picture D. I don't know if it's evident. So if you apply the same amount of gas, same PEEP, to one lung or to half lung, you may cause damage. But you apply the same amount of gas, same amount of PEEP to both lungs, you probably will do better with regards to airway pressure and less damage and harm to the lungs. So, of course, nothing is without negative effects. And what are the negative effects of PEEP? PEEP will decrease preload through increasing intrathoracic pressure. PEEP may cause barotrauma, and Dr. Haddadin said that he wants to titrate PEEP, but he also wants to look at the plateau pressure to make sure he's not causing damage to the lung, which is the right answer. PEEP can cause regional overdistension, like I said here. I think, and I may be wrong, but I think there is regional hyperdistension in image B because you applied PEEP here, you caused that part of the lung to distend while the others were still atelectatic, okay? So you may cause regional damage to the lung. PEEP will decrease RV preload and PEEP will increase RV afterload. So using of higher PEEPs in patients with known pulmonary hypertension RV dysfunction can be counterproductive. Another thing to keep in mind is that ARDS can be focal and can be diffuse. When it's focal, you have to titrate your numbers and make sure that you're not causing damage to the parts that are healthy, because you don't want to lose the healthy part of the lung while trying to save a patient on mechanical ventilation, okay? And also, we're going to talk about certain methods that can help you titrate PEEP in these conditions. So now let's go by, let's review the methods that are available to you to titrate PEEP. We're going to start with the ARDSNet table. The ARDSNet tables are tables that were used in the ARDSNet trials, okay? And these are widely used. They have, of course, guidance on how to manage the vent. They start by adjusting tidal volume based on predicted body weight, which depends on the height of the patient. They have certain goals that have to be met, like a plateau less than or equal to 30. And then they provide suggestions of PEEP based on the FiO2 you're using. The lower PEEP table, of course, has the lower values. The higher PEEP table, in my opinion, is very high, okay? So when Dr. Haddadin said he wants to use a PEEP of 10 because the FiO2 is 100 and that's high, that is not high, that is actually low, because in a high PEEP table, you would use 22 to 24. In a low PEEP table, when you reach 100, you use 18 to 24. Okay. Now, I don't advocate everyone to be on 18 or 24. These are guiding parameters to be used when you also follow the first part of the algorithm, which includes adjusting tidal volumes and making sure the plateau is low. So putting someone on a PEEP of 24 just because their FI2 is 100 and ending up with a plateau of 40 is counterproductive. That will cause harm. Okay, so you can look at the table, but you also need to make sure your tidal volumes are low. You need to make sure your plateau is less than 30. Okay. I personally, if I want to start blindly, I start somewhere in the middle. I think a PEEP of 10 for FI2 of 60 in the acute setting is too low, but I also would not jump the gun and go to a plateau of 20 as the high PEEP table without doing certain maneuvers that we will learn in this lecture. So the ARDSNet tables are good because they're easy to implement. They don't require a lot of work, but the problem is they assume one size fits all, and one size does not fit all. Like we showed you in that picture, the patient who was morbidly obese may need more PEEP. So you can't just go by the same number on Saddam, if God forbid Saddam is on the vent, than on that patient with a BMI of 45%. Another thing is that it does not consider regional variations. So if you have a lung that is full of pus and pneumonia and another lung that is open and you use the high PEEP table, you may be causing damage to the good lung because you're hyperinflating that good lung. Okay? Now, the question as to which table is better has been studied as well, to use the high or the low table. This is a meta-analysis of 6 studies that looked and compared the high versus low PEEP tables. With regards to mortality, you can tell that there may be a trend towards favoring higher PEEP, but the net of all of these studies touches 1, so this would not be statistically significant. Okay, so it seems like there is a trend towards improvement, but in this meta-analysis, they did not find a statistical significance towards higher PEEP improving mortality. Okay. Now, another trial looked at comparing high versus low PEEP tables in patients with ARDS who have a PF ratio of less than 200 versus those without. And in patients with ARDS who are hypoxemic with a PF ratio of less than 200, higher PEEP tables in this study showed improved survival and improved days to unassisted breathing. So there was a benefit of using high PEEP tables in this study versus in people with ARDS that are hypoxemic with a PF ratio of less than 200. Now, high PEEP tables do improve oxygenation. Okay, so the same meta-analysis that I showed earlier, when they look at oxygenation as an outcome, not as mortality. Here, the outcome was mortality. Here, the outcome is oxygenation, and it shows that high PEEP tables improve patient oxygenation. Now, there's one very important concept here, and this question is for third-year fellows. So, Dr. Mina, I saw Mina was there.
I am here.
Is he there, Mina?
Yes, he's there. Yes.
Mina, how do we treat ARDS? What is the general concept of treating ARDS?
Trying to protect the lung.
Exactly, supportive care, right? So I'm protecting the lung until the lung heals. Improving oxygenation does not improve mortality.
Exactly. That's the difference between the 2 studies. Here, one of them, higher PEEP, showed you that you have good oxygenation, but it didn't affect your mortality. So
yeah, and the reason I mentioned that is you can keep people at a FI2 of 100% for days, right? And then oxygenation will look good. But the key to improving mortality is what you said, is to support the lung until the lung heals and causing the least amount of damage, right? So that may result in improved oxygenation, okay? For example, you may prone someone with a SAT of 95. I mean, they're satting 95. Why would you prone them? You would prone them because their PF ratio is very low, and we know that if we do it early, you might recruit lung, and with lung recruitment, airway pressures improve, oxygenation improves, time on the vent improves, hence mortality improves. So oxygenation, although it's a goal of putting it like it's part of the support of a sick ARDS patient, but the oxygen number per se does not result in improved mortality. Otherwise, the use of inhaled nitric oxide would improve mortality. It does not. It may improve oxygenation, but it may not improve mortality because you have to make sure that you're protecting the lung and causing as little as possible lung damage until the lung heals and the patient can be liberated from mechanical ventilation. So again, ARDSNet tables are easy to use. You can refer to them if you don't know where to start. I would caution against using the very high-end numbers without making sure that you're not causing damage with a plateau less than 30, okay? But you can always use them. If you want to use them, make sure you're following their guidance on low tidal volume and a plateau of less than 30. Now, another concept is the driving pressure, and this is a concept that is gaining more momentum. Remember, in lung protective ventilation, we adjust tidal volume based on predicted body weight. That does not consider lung compliance in the equation. You just go by the height, you use certain body weight, okay? So there is a thought that if you titrate tidal volume to compliance, you may end up with better results. And hence, we're going to talk about the driving pressure. The driving pressure is the ratio of tidal volume divided by lung compliance. So how do these interact together? So, Rami, if you have a compliant lung, do you expect that lung to increase, if you increase the driving pressure, if you increase the tidal volume by 100 points and the lung is compliant, do you expect the pressure to increase more or less than a fibrotic diseased lung?
Because you can again, the extra volume is going to be distributed on the compliance, so eventually the pressure is either going to stay the same or increase a little bit more.
It will decrease because you're gaining more volume, right? So
yes,
the equation is tidal volume divided by compliance.
Like
so as the compliance
blowing in a tire, technically.
Right. As the compliance increases, the change in pressure will
drop.
decrease. Now, you can estimate driving pressure by subtracting PEEP from plateau pressure. This is how we do it at the bedside. PEEP minus plateau, plateau minus PEEP is the driving pressure. One of the famous trials, and you'll see this graph used a lot, is the Amato trial in 2015. They took 3,560 patients from 9 randomized controlled trials, and they examined driving pressure as an independent variable associated with survival. So they took these patients and they sampled them in 3 different ways. The first way, they matched them using PEEP. So they put them in groups based on PEEP. And they looked at their driving pressure. And look at what they found. If everyone is matched on PEEP, so they're all getting, if groups of patients are getting the same PEEP, if their driving pressure goes higher, the mortality goes higher. So the lower part of the curves show the relative risk of death in the hospital, and the upper is the airway pressures, okay? So as the driving pressure, which is in gray, increased, the mortality increased. Then they resampled the patient and they matched driving pressure. They said, we're gonna put all these patients in the same group based on driving pressure, okay? And what they noticed is for the same driving pressure, mortality is the same. So if I group patients based on driving pressure, the mortality was the same. Then they went back and they matched patients based on plateau pressure. And what they noticed is as the driving pressure decreases, you can tell here it's the opposite. The gray is getting smaller, the mortality will drop. So what they noticed is that if you compare these two graphs, higher plateaus may not always be risky, right? Because achieving a higher plateau but the same driving pressure did not result in more mortality, okay? Now, they also noticed that higher PEEP is not always protective, because higher PEEPs without the benefit of a smaller driving pressure did not improve mortality. So what they're trying to say is that lung compliance factors into the equation, and setting up numbers without looking at lung compliance may not be the best strategy. And the number they're talking about is the driving pressure. They want us to target driving pressure. Another study looked at numerous ARDS patients in different aspects. And one aspect they looked at was driving pressure. They put them into groups. This was in 2016. They put them into groups, as you say, in the x-axis, based on driving pressure. And they looked at the probability of death. And as the driving pressure increased, the probability of death increased. Same with the plateau pressure. Now, they looked at a cutoff driving pressure of 14, and they noticed that a driving pressure of less than or equal to 14, as you look in the dotted line here, was actually associated with more survival. That's why you sometimes hear the driving pressure should be less than 15. Okay, why? Because this study showed that when the driving pressure is less than 15, which is equal or less than 14, then you have better survival. Okay? Now, one caveat to these studies is these are not studies that looked at driving pressure as a goal. Meaning, the first one, Amato, it's a New England Journal published paper, but this paper did not design a trial where they said we want to have a goal driving pressure of 15 and compare other factors. Okay? So we don't know. We just know that higher driving pressure is worse. But that can be, in my opinion, simply because the lung is so fibrosed, right? Rather than a goal I need to achieve in titrating my PEEP. So this was a recent pilot trial. Okay, so they implemented the protocol. They wanted to say, okay, we want to target driving pressures. And they did a pilot trial. I don't know. I think the larger trial may still be ongoing. Okay, but in this pilot trial, what they did is they took 31 patients with ARDS. They put 16 in the driving pressure group and 15 in the conventional group, and they targeted a driving pressure of 10. And to achieve a driving pressure of 10, they kept going down on the tidal volumes until they reached a minimum of 4. And they said, we're not going to go below 4. So if you have a tidal volume of 4, and the driving pressure is above 10, they didn't go below 4. And this was just a pilot trial to see if the protocol is feasible or not. So I just want to show you a few things here, and I highlighted them with red arrows, to show you what happens when you target that low driving pressure with that low tidal volume. So first of all, they could not use, they used low PEEP tables, okay? And I don't think using high PEEP might have been easy, because sometimes if you use high PEEP, you result in a more significant increase in the driving pressure. So they used low PEEP, and their plateaus was low, as you would expect, but the respiratory rates were high. So on day 1, they were in the 30-33 range. Then we're talking about 35, okay? So in order for them to keep the PCO2 low with a driving pressure of 10 and a tidal volume of 4, they had to crank up the respiratory rate very high, okay? And they were limited on how much PEEP they can use. So that presents a challenge. Okay, so again, the concept, so I'm gonna ask another question. Rami's there?
Yes.
So Rami, if you have a patient on a PEEP of 12, tidal volume of 450, a plateau of 28, what is the driving pressure? Plateau 28, PEEP 12.
So 28 minus 12 is
16.
16. Okay, so how would you reduce the driving pressure? What can you try to do to make it below 15?
I will start with the tidal volume actually.
Exactly. You will drop the tidal volume and remeasure the plateau.
Exactly.
Okay?
Yeah.
Right. So, but we don't know how to implement that without causing optimally. Let's just say optimally. So, first of all, higher driving pressures are associated with worse outcomes. We know that. There's a lot of studies on that. But is this in mind? This is a question that I would ask. Is it a measure of disease severity? Because a lung that is very fibrotic, diseased, bad ARDS, will generate more pressures than a lung that is healthy, okay? So is this finding on these studies a result of lung issue, of a diseased lung? Or is it because we did not titrate to driving pressure? I don't think we know the answer, okay? Now, like Rami said, he wants to reduce the tidal volume. That comes at an expense. You will have hypercapnia. You will use higher respiratory rates. You know, there's a concept of mechanical power. The more power you put from the machine into the patient, the more damage you get. And respiratory rate factors into that. So should I drop the driving pressure from 16 to 14 by causing hypercapnia and increasing respiratory rate, let's say from 25 to 30? Is this better than keeping the patient at a driving pressure of 16? I don't think we have the true answer to that, okay? Now, should I compromise on my PEEP to be able to get a driving pressure? Maybe yes, because if you're using higher PEEPs and that's resulting in in too much increase in your plateau, so you increase the PEEP by 2 and the plateau disproportionately increases by 6, then you're crossing a level and you're causing hyperdistension. So that maybe yes. And remember that the Amato study was not a study done using driving pressure as a goal. And this is important, right? It was a reanalysis of a lot of other studies. Now, we can say we're not going to target driving pressure. We're just going to put everyone on 4 mils per kg and see what happens. Because if you put everyone on 4 mils per kg and you say, I'm not going to go lower, then you don't care about driving pressure. That's the least driving pressure you will have. Okay? And again, what is the optimal goal driving pressure? We don't know. So we need further data to know how to integrate the number. We know that a higher number harms. And we know Dr. Batarse knows how to drop the number. Okay? But how far should we go to drop the number? Should I say, okay, if someone's pH is 7.3, I'm going to artificially reduce the tidal volume to drop the driving pressure and tolerate a pH of 7.15? Is that really better? I do not know if we have the answer, okay? So now let's move to esophageal manometry. Esophageal manometry is not commonly practiced or used, but we have it, we use it, and I think it's a very helpful device, okay?
Dr. Bandak,
So, sorry?
quick question. On that pilot study, did they target a certain plateau pressure below 30?
No, so I showed you their plateau pressures were very low. So you're talking about 19, 24, 20, 16. It could be that patients were not that sick, but remember they used low PEEP and they used very low tidal volume, okay? The mean tidal volume was 4 in the intervention arm. So you can just say, I'm gonna put everyone on 4 instead of measuring a driving pressure, you know? So yes, their plateau was low, their PEEP was low, their tidal volume was low. And maybe in this pilot trial, they did not have severe ARDS, I don't know.
Because sometimes when you use a higher PEEP, you can actually decrease your plateau pressure, your driving pressure by recruiting.
Yeah, of course, if you recruit lung, of course, right? So that's what I'm saying, is driving pressure versus high PEEP. So I don't know if we know by now that driving pressure should be the ultimate goal, okay?
I guess that question would be driving pressure versus plateau pressure.
It could be, yeah. Because like if I go back to the Amato trial, or the Amato study, sorry, they showed that higher plateau is not always risky, right? Because if the driving pressure is the same, you achieved the same mortality. Now again, this was not a goal, this was a result. So you don't know. So what Dr. Shihata is saying is, should we say we don't want to look at the plateau, even if the plateau is above 30. The most important thing is to have a driving pressure less than 15. Is that a sensible goal? Would that result in harm? I don't know.
I have another question if you don't mind. So let's say that we are trying to recruit more lung depending on our driving pressure. So how much time would you actually give it between you adjust your PEEP until you get to titrate your driving pressure?
That's a good question. So they should go hand in hand. But I think the Rami is saying if you increase PEEP, if you give it time, the lung will recruit. So I don't know, to be honest, the exact answer. I will tell you this. In recruitment maneuvers, it happens instantaneously. You increase the PEEP to 40 seconds, you drop the PEEP, and the machine, and the machines that have a built-in function, will tell you how much lung you recruit. And you can tell that the airway pressures are better, okay? But sometimes you put someone on a PEEP of 14 or 16, and you come 12 hours later, you repeat the X-ray, the lung is better, and you measure the plateau, and the plateau is better. So that PEEP you placed needed time. But what you should do, or what RTs should do, is they should measure the plateau, if you're targeting plateau, every 4 hours, and do adjustments accordingly, okay? But you're right, sometimes it takes time for the lung to recruit, so just give it time. I don't know the exact answer as to when would you say this PEEP failed to recruit.
Do you mind if
Yeah.
So the PEEP changes, if you make changes to the PEEP, you have to evaluate immediately. You know, there's some people who say, well, I'll increase the PEEP by 2, but then I'll come back 2 or 3 hours later and evaluate. I'll evaluate hypoxia, evaluate blood pressures. So for example, you can increase the PEEP by 2, and if his plateau pressure increased by 1, that means you recruited, right? If it went up by 2, maybe you could give it some time. But if you increase the PEEP by 2, 3, or 4 during this time, and then the plateau pressure goes up to double, like goes up by 8, for example, or something like that, then you're telling you that your lungs may be too stiff, and he's not responding very well to increasing your PEEP. So that's how you, I don't think I'll wait a few hours. I would not wait 12, 18 hours to make a decision about small changes in PEEP. But you're right, you can increase the PEEP, and I would just, what I would say is I would come back maybe 2 or 3 hours later to evaluate how the patient is doing. If he is less hypoxic, not hypotensive, things like that, and like I said, his plateau went, increased only by 1 or did not increase at all, then I think that you're recruiting, and I would just keep going until he hits that threshold. Some people, they talk about doing recruitment maneuvers, they talk about doing it very slowly, some very quickly. I think as long as you evaluate,
But do
that's
we
the main
do like the 40-40 in our ICU? I have never seen anybody do the 40.
No. Well, that's true. I can do 40-40. There's. I don't know if Dr. Bandak's going to talk about that. You mean talk about 40 PEEP for 40 seconds?
Yeah.
Yeah. So
We're not talking about recruitment maneuvers, no. But recruitment maneuvers vary. There are studies on them. What the vents we had bought and we may start using soon have a built-in one that you control. You say, I want to increase the PEEP for this amount of time, for this amount of seconds. But I'm not talking about recruitment maneuvers and studies of recruitment maneuvers in this talk. Okay? And for the sake of time, let me just go through, because we have 11 minutes left, okay? So let's talk about esophageal manometry. I just want to say that I agree with what Dr. Al-Jasmi said, is that you have to be at the bedside and come back and reevaluate. If you do a change and you want to give it time, don't give it 12 hours. Okay, you can give it a few hours, come back, reevaluate. So it's very important for you to be at the bedside frequently if you're doing adjustments and evaluating the effect, okay? So esophageal manometry. First, let's remember, the transpulmonary pressure is the net distending pressure on the lung. And you can measure that by subtracting the pleural pressure from the alveolar pressure, okay? In a spontaneously breathing patient, the transpulmonary pressure is positive because the pleural pressure is always negative. The alveolar pressure changes from slightly positive to slightly negative. The net gain is air going into the lung. If the transpulmonary pressure is 0, that means the alveolar pressure, the pressure within the airways and the respiratory units, equals the pleural pressure. And that can happen, for example, in pneumothorax or lung collapse. When you have a pneumothorax, the pressures equalize and the lung collapses, because remember, there's a tendency for the lung to collapse, okay? Now, why use esophageal manometry? Remember, the equation of motion measures resistance and elastance and pressures, but it does so, and the vent, the numbers the vent gives you is mostly for the respiratory system. And the respiratory system includes the lung and the chest wall and the muscles. And there are different ways and different things you have to do to try and isolate the pure numbers affecting the lung itself. For example, a measured airway pressure may ignore components of chest wall and chest wall deformities. If you have a pleural effusion, if you have massive ascites, abdominal compartment syndrome, obesity, all these are factors that can affect the respiratory system compliance, not necessarily the lung compliance. So you're applying a lot of pressure extrinsically on the lung. So when you measure the airway pressure using the vent, the number you get does not reflect the true distending pressure in the lung. Okay? And this is, I hope this image would be helpful to explain things more clearly. This is the alveoli, airways, and this is the trachea. When the vent measures airway pressures, it measures them here. Okay? And that involves the pressure within the airways. And that we assume is the alveolar, we consider the alveolar pressure. Now you do have a pleural pressure as well, and this transpulmonary pressure or the distending pressure is the airway opening pressure minus the pleural pressure, okay? If you don't calculate the pleural pressure, then the only pressure you get is the airway pressure. And in some conditions, that's a good surrogate. In someone who's not morbidly obese, does not have compartment syndrome, no chest wall deformity, we take this pressure as the true distending pressure, and we say we need the plateau to be less than 30 to prevent lung damage, okay? However, in certain conditions, the ones we talked about, a plateau of less than 30 may not, you can go beyond 30 simply because there's a major component of that pressure, of that measured pressure, that is not truly affecting the lung, okay? So to do that, you have to estimate the pleural pressure. And one way of doing it is putting an esophageal pressure monitoring probe. You put that at 35 in the lower third of the esophagus, 35 to 45 centimeters. The RT verifies placement because the waveform will have will have cardiac oscillation, so you know you're close to the heart, okay? And that will give you the pleural pressure. And then the machine, our machine, because it can integrate with the esophageal balloon, can give you the transpulmonary pressure, okay? Now, this concept was studied in 2008. And what they did is they said, we want to target a transpulmonary pressure at end aspiration of 25 at max. This is your plateau, okay? And we want a transpulmonary pressure at end expiration of 0 to 10, depending on FiO2. So what they did is they had FiO2 PEEP tables similar to the ARDSNet tables. They said if the FiO2 is this should be your transpulmonary pressure at end expiration. So remember, at end expiration, patient has exhaled all the tidal volume, okay? This is when the lung can collapse and go into atelectasis. That is why we use PEEP, okay? Now, if you have a lot of extra pressure on the lung, the pleural pressure component is high because of morbid obesity, pleural effusions, compartment syndrome, then at end expiration, the lung might collapse and go into atelectasis, right? What you need to do is to use much higher PEEPs to counteract these forces. And sometimes the plateau will end up being more than 30. But in this setting, you don't care or you don't think you're causing harm because this pressure that you're measuring from the airway, part of it is not causing harm on the lung. Part of it is going to overcome the effect of the morbid obesity or the massive ascites or abdominal compartment syndrome, etc. So they did this study in 2008, and what they did is they only enrolled 61 patients because the trial was stopped early because they achieved their goal. The primary goal was oxygenation and not mortality, okay? And what they showed is that using esophageal guidance, you will get better oxygenation, you will get better compliance because you're recruiting more lung, okay? But they did not show a mortality benefit. There was a trend towards mortality. The p-value was above 0.05. And remember, the study was halted early, and the main goal was not mortality. So this study was suggestive that use of esophageal balloons may be helpful. Instead of looking at a plateau pressure, use the esophageal balloon and titrate PEEP towards the transpulmonary pressure. Okay. Now, another trial called the EP-VENT2 trial came later. 200 mechanically ventilated patients, moderate to severe ARDS. Their primary outcome was a composite of death and days free of the ventilator, and they showed no significant difference in primary outcome between treatment groups. The way I interpret that is you do not need an esophageal balloon in everyone, okay? There are certain people where you suspect that measuring a plateau pressure alone is not enough, and you may want to get more PEEP. You just need to be sure you're not causing harm, okay? And in this patient population, I would still use an esophageal balloon. The EP-VENT2 trial showed that there was no benefit if you use it on everyone. Now, there was a post-hoc analysis that Dr. Shui had just sent you guys. And what these people did is they took the EP-VENT2 trial. They wanted to evaluate whether multi-organ dysfunction and lung mechanics modified the treatment effect. So they did different analyses. First, they looked at Apache scores. And they showed that Apache scores, if the Apache score is low, using esophageal balloon to titrate PEEP resulted in a better mortality as opposed to higher Apache scores. They also showed that if you target an end expiratory pressure of 0 plus minus 2, so the transpulmonary pressure of 0 plus minus 2 using the balloon, the probability of survival is higher than if you're too little or too high. And what that means is the following. If you're under PEEPing, or if you're causing hyperdistension, under PEEPing meaning the transpulmonary pressure is low. You put the patient on a PEEP of 12, but the actual transpulmonary pressure is negative. So with every expiration, the lung is collapsing and opening, and you have a lot of atelectotrauma. If the transpulmonary pressure is 5, that means you're using too much PEEP and you're hyperinflating. And in both of these conditions, they showed that mortality is worse. So titrating your PEEP to 0 plus minus 2 resulted in better survival. It also resulted in better shock-free days and better ventilator-free days. Okay, so if you titrate your transpulmonary pressure to 0 using an esophageal balloon, you may get better outcomes. Now I'm going to talk about another way so we already talked about 3 ways you can titrate your PEEP. You can follow the tables. You can titrate for a driving pressure of less than 15. You can use an esophageal balloon to make sure your transpulmonary pressure is 0 plus minus 2. Now, what is the stress index? The stress index shows how much the volume in the lung is the pressure within the lung, within the respiratory system, is changing as you build up pressure within the lung. And in order for you to evaluate the stress index of the lung, the flow has to be constant. If you look at our vents, the flow scalar in most of them is decelerating. So you have high flow at the beginning and it slows down. Okay? When you want to evaluate the effect of increasing pressure on the lung stress, you have to have constant flow, so that the only variable is the buildup of pressure within the lung. Okay? So we have to change the flow to a square waveform, and you can do that on the vents. I do it transiently when I'm looking at it. This is the airway pressure scalar, right? And you can tell here, for example, that as gas fills the lung, pressure goes up, okay? but it does not. It goes up less and less with time. In the second, and this is a stress index of less than 1. Okay. In the second part of the graph, you can show that as the breath goes on and the lung is filled with gas, airway pressure increases in a constant fashion. If the stress index is above 1, that means that as you're filling the lung with gas and the airway pressure is increasing, it will start to increase disproportionately higher as it's filled more and more and more. So you're causing more pressure for amount of gas. Okay? So they postulated that if we adjust the PEEP to normalize the stress index so that it's not hyperinflating or low inflating, okay, you will get better outcomes. Because in this means that the lung is opening and closing equally with increasing pressure, right? You're not achieving, because remember, like Rami said, it's like a balloon. So this balloon, if it's already too inflated with a lot of pressure, you might cause hyperinflation with every breath, okay, if you keep insufflating gas in and out. Or the opposite is you're not getting enough inflation. So you adjust the PEEP so that throughout the respiratory cycle, the increase in pressure and the stress index of the lung is 1, something like here in the middle. What they noticed is when they dropped the PEEP to normalize the stress index, so they went from the third curve here, stress index of more than 1, to stress index equals 1, the lung elastance, the inflammatory markers were significantly lower. So one thing you can do is after you set up your PEEP, switch the flow to square waveform and look at the stress index. If the stress index is curving up at the end, you have to drop your PEEP. Another concept, and this is a part of the concept that is used in a recruitment maneuver, is called the lower and upper inflection point. So this is a curve that shows, this is a volume pressure loop, okay? And as you add pressure to the lung, you are recruiting. The lung becomes more and more inflated. There's a specific point called the lower inflection point, after which you achieve significant rapid increase in volume and recruitment. So if we start here at the beginning, we're increasing PEEP slowly. You go from a completely atelectatic lung to a slightly more inflated lung, okay? And you're achieving more and more volume. There's a point after which, if you increase pressure, you will get a significant increase in lung recruitment and in volume until you reach the upper inflection point, which is the point after which you cause hyperdistension. So you want your PEEP to be somewhere between the lower and the upper inflection point. And you want your PEEP to be no less than the lower inflection point. If you remember the first graph I showed you for the CAT scans, so when they used the PEEP of 11, that probably was barely the lower inflection point. They have to go to a PEEP of 40. They could have probably gone to less than 40, right? Who knows? But they went for 40. And then when they went back to 11, 11 was enough to keep the lung open, meaning 11 was above the lower inflection point, okay? So these graphs are available on the vent, of course. And if you have a vent with a built-in recruitment maneuver, it will calculate the point for you. So as you increase pressure, there is a point where you will cause significant recruitment for small increases of pressure. The response will be great. And there's a point where it will be counterproductive to go beyond. And that's the upper inflection point. So you can say, I titrated PEEP to 2 points above the lower inflection point. The lower inflection point was 12. I placed my PEEP at 14. It's less than the upper inflection point. So I gained recruitment and I did not cause hyperinflation of the lung. Finally, and most interestingly, this is a brand, I don't know how new it is. It's new to me. I learned about it in the past 2-3 years. Something called electrical impedance tomography. So basically, some vents now have the capability of creating dynamic images to show you how lung expands and collapses during a respiratory cycle. For example, in this image, it shows you how during inspiration, the right lung is inflating faster than the left lung. And during expiration, the left lung is collapsing faster, right? So how can you use these images to titrate PEEP? How can you use the knowledge of dynamic inflation and hyperinflation in a lung to titrate PEEP? This is one example, okay, of a case where they took a patient and at a PEEP of 10, there was this white here is how much lung is atelectatic and collapsed. There was a lot of atelectatic collapsed lungs, okay? At the PEEP of 14, you won some. You gained volume, lung volume. So you recruited lung volume. However, there is win and loss. So you lost some recruitment and you won some recruitment. And there was a little bit of loss here, and that may be because of hyperinflation, okay, over distension and collapse. So CL is collapse. Here collapse was 22.8%. When you went to a PEEP of 14, collapse went to 1%. See, this very tiny, in picture E, there's a little bit of white here. All the white went away. But you had 16% over distension. This purplish color here is over distended lungs. And you can correlate here that the hyperdistended lung had less win compared to the collapsed lung that we recruited. So all this white was collapsed. You increased the PEEP to 14. You recruited all this white, but at the same time you caused hyperinflation. So at the PEEP of 12, you actually achieved the balance where your collapse is low, your overdistension is low, and you gained a lot of recruitment. So then you choose a PEEP of 12. Okay, so let's go back. At a PEEP of 0, we want to evaluate PEEP of 12 and 14 compared to 10, whether you win or lose compliance and whether you cause overdistension or lung collapse. So as you went to a PEEP of 14, you gained compliance in the blue here, and you lost a little bit of compliance here because you caused overdistension. You overdistended the lung. At a PEEP of 14, you achieved a better balance. There is not a lot of white. White is collapse. There is not a lot of purple. Purple is overdistension. And most of the image is showing gained compliance. Okay? So some of these vents actually will do a maneuver and give you the cross-section between overdistension and compliance and suggest that as the appropriate PEEP. The good thing about this mode is I think it may factor in more asymmetrical ARDS focality rather than what we usually use, because what we use usually treats the lung as a single unit. But sometimes part of this unit is functioning, the other part is dead. So this may be the part of the challenge of titrating PEEP. So maybe using EIT can be better. Okay, does anyone have any questions for now?
Just one question for the stress index.
Yes.
Can we apply that for the mode like a pressure control, just because you say the flow should be a fixed variable?
I think it has to be volume control because you do not control flow in pressure control. In volume control, you control flow. And by control, is standard. It has to be the same. Because the concept is you have a bag and you're flowing gas into this bag. How does this bag react to the flow of gas? Mm-hmm. If you're giving the flow at variable rate throughout the breath, then the changes you see may not be purely due to pressure changes. They may be due to flow changes. If you push a lot of air fast, then you slow down. The buildup of pressure across time might not be purely because of PEEP, okay? Because you gave pressure at variable rates. You want to control everything and leave the only variable to be the effect of the PEEP on the stress index. And I will double check that, but I think I don't think you can do it, because I don't think you can guarantee constant flow rates in pressure control.
Thanks. Thank you.
Any other questions?
Yes, please. On the esophageal manometry, so the way
Yes.
that you explained it, in a way or another, the goal is the delta pressure is summing up the factor of the P mass and the wall and deformity, etc. So I was just thinking, so if you have an obese patient, okay, let's say you're using a PEEP of 10 or 12, high PEEP, 14, a PEEP that technically you cannot extubate in, but your esophageal pressure, let's say it's 0 or 1.